calling we're activating our rapid response teams more frequently. Next thing we did was look at the respiratory therapist. And the respiratory therapist, we're looking at the ratio of the respiratory therapist versus the patients. And again, it was a very high ratio that we had. The number of patients that the respiratory therapist had to see were more than we would have wanted them to see. And again, it's just because of the intensity of the situation, and the hospital was full to capacity at every given time. And the respiratory therapists, everyone was exhausted. It was a lot of work. And so they ended up, the ratio was a little bit higher than we would want it to be, or we had expected. And then we also realized that the respiratory therapists did not have any formalized rounding tool, and they were not and they didn't have any formalized rounding methods also with nurses or physicians. So there was no rounding tool and no rounding methods. And this we thought was one of the major things that was impacting the deterioration and the need for rapid response team activations. Then we looked at physicians also. And again, we looked at the communication that existed between physicians and the respiratory therapist, and there was no clear modality of communication. Most of the respiratory therapists could not directly answer phones when they were taking care of patients, and they couldn't run out every second to answer pages. So there was not really any direct communication right there. Communicating with the respiratory therapist did require some time. And we also thought, well, maybe physicians should evaluate the patients a little bit more frequently. And that is one of the aspects we looked into. Another thing was the equipment. And again, some of the equipment was not readily available, not because we didn't have the equipment, but mostly because access to this equipment was limited, mostly to respiratory therapists. And again, the truth is also that the respiratory therapists were the only ones who were trained to use some of this equipment, that they are the only ones who had access to. So we looked at that thinking, if more people had access to this equipment, would that have helped? But that became very questionable also, because if I had access to equipment that I couldn't use, it was useless anyways. So, but we looked at that also. And then with regards to logistics, because we had so many sick patients, we had a good amount of patients in the ICU. The ICU beds were limited, they were full at all times. Were we unintentionally or intentionally somehow admitting patients who had to be in the ICU on a regular medical COVID unit? That was a question. Are these patients who require a higher level of care, and we're leaving them in the COVID unit? So that is a question that we had to keep asking ourselves. And we did not have a step-down unit for COVID patients. So we didn't have a COVID step-down unit. And again, this kind of like placed us in a situation where maybe a patient who should have been at a step-down level of care was directly admitted to a regular COVID unit because, again, there were no ICU beds. And so all of these things were things which I think we could have been able to tackle in order to reduce the number of rapid response team activation in our patients with COVID or in the COVID unit. But then looking at everything, we decided to go ahead and tackle what we thought was one of the most influential things that could be easily fixed also. And this was the fact that the rapid response, the respiratory therapists were not evaluating the sicker patients in a timely manner. They were not prioritizing their rounds. And so they were very slow to, again, evaluate these patients. And so once we realized that was the case, we had to go ahead and ask ourselves why this was the case. And so we went ahead and did the 5 whys. Why were they not evaluating sicker patients first? Why were they evaluating maybe patients? They were evaluating according to a geographical format. So they will start from the intensive care unit and then go to the next floor, and then before they get to the COVID unit. And so getting to COVID unit was usually delayed. And why was that the case? We realized that. So our first why was, why were Zika patients not evaluated in a timely manner? The second why was, and the answer was because rounding was not prioritized, right? Based on patients' clinical conditions. They were doing geographical rounds rather than making sure that they see the sickest patients first. And why was that the case? And we thought it was because the respiratory therapists were not aware of the Zika patients. We did not tell them which patients are sicker than others. And why did we not? Why were they not aware? It's because primary inpatient providers did not report this information. We did not tell the respiratory therapists that, hey, these are the sickest patients. When you come in the morning, please go ahead and round on these patients first. We did not give them that information, so they did not have that information. And why did we not give them this information? I think it's because we did not have a reporting tool in place to be able to give them this, or we didn't have a process in place to report the fact that these are our Zika patients, and please, when you come in, round on these patients first, prioritize rounding on these patients first. So we decided to create a reporting tool at that point, and this reporting tool was just an Excel file, an Excel sheet that was shared on Microsoft Teams with all the multidisciplinary teams caring for these patients, so each of our patients. And again, with a clear emphasis on respiratory therapists being involved. So it was a very simple tool for people who are familiar with Microsoft Teams. We put this tool on the Teams. You just had to put in the patient's name, the patient's last 4 digits of their social security, and that is usually what we use as medical record numbers here. You put the patient's room, and if this patient has already been seen by respiratory therapist. If the patient has not been seen by a respiratory therapist, you consult the respiratory therapist. You call them and let them know that this patient is sick and may need to be seen by them sooner than later. And then you put their current oxygen requirements, and you put a comment about the patient if you had any comments you wanted to put in there. And this document was shared amongst everyone who was caring for the patients. So all the respiratory therapists who were coming on service had access to these documents, and these documents could be updated in real time to let them know who had to be seen, and we could add someone to the list, take out someone from the list. And it was longer than this, but I just put in the list to show how it looked like. And they could see the patients, send us a message, communicate in any way, shape, or form. We gave access to the nurses who were taking care of those patients also. So it was more like a multidisciplinary team tool, but we were targeting the respiratory therapist. So just with prior to our intervention, we had so we did our intervention at a certain point. So this intervention was actually done around March of this year. So we took the 3.5 months prior to March of 2021. And again, at that point, we had 68 rapid response team activations on the non-COVID units. And then we did our intervention, and 3.5 months later, we had 71 rapid response team activations on the non-COVID units. For the COVID units, though, we had 33 activations of the rapid response team. And after our intervention, we had only 23 activations of the rapid response team. So this was a reduction of about 10 rapid responses. So, or I would say almost 1/3 reduction in the number of rapid response teams that were called to the COVID unit after the intervention. Of note is the fact that we did this intervention only for the COVID units. For non-COVID units, we did not intervene. So we were not giving them that sign out and giving them all the information that was needed. So totally, for the pre-intervention period, we had 101 patients, and post-intervention period, we had 94 patients. And just of note, the difference was not statistically significant. The p-value was 0.26. So again, the weaknesses of this is that we had a small sample size. And I do strongly believe that the fact that we had just 33 patients, 33 rapid responses before the COVID, before the intervention, and then 23 post-intervention, actually influenced the fact that the studies were not statistically significant. And this, again, the reason we had just this poor sample size is because when we started this intervention, COVID, we already had very high vaccination rates in the United States. We already vaccinated a lot of patients locally. And so we were no longer having a lot of COVID. We're no longer having a lot of COVID patients. So the numbers were dropping drastically. And so it was virtually impossible for us to have the sample size that we would have wanted to have. But I do strongly believe that if we had the appropriate sample size, this study would have come out, this intervention would have been statistically significant. So for the future, I think we should consider creating a multidisciplinary team sign-out tool that can be accessed by all care teams. One of the things that is common here with sign-out is that when there is need for, we do sign-outs only between physicians to physicians, and one physician, and the physicians who are covering overnight are the only ones who have maybe some information that could not be in the chart, like some warnings, like if this happens, you should do this or that. I think we should consider creating some form of tool that can be shared with other multidisciplinary teams so that they can also be able to access the vital information and be able to look at it in a minute and be like, okay, this is what I should pay attention to, rather than having to read the entire chart if something happens in an emergency situation. So I will conclude by saying that caring for patients with COVID-19 presented severe challenges because these patients, COVID-19 was very unpredictable. The patients would deteriorate at a faster rate. They required very high levels of oxygen most of the times. And again, this was a very highly contagious disease with high morbidity and mortality. And so just actually having the physical care for these patients made it also a little bit more challenging with all the PPEs that were required, donning and doffing and all of that. And then also, one of the other conclusions, one of the take-home points I want us to have is that creating multidisciplinary team sign-out tools may reduce the number of rapid response team activations in COVID units. And I would even dare to say that probably if we have even other conditions, we have like flu, during the flu season is coming, and we should consider having this type of tool to be able to share information. And then last but not the least, I do think that, and as I mentioned, with a larger sample size, we may have been able to have statistically significant results. But again, medicine does not deal only with you having the outcome that you wanted. I think we also have to kind of showcase cases like this where the results may not be what we wanted. Thank you very much. And any questions? I'm open to any questions at this time.
Joyce, I'm working in a pediatric ICU. So we also started with our PRRT, and I must say, it's a learning curve for people to call for that and rather not do a code. And if they can start earlier, it's much better. But I also see in my hospital is that we don't see so many children with COVID. So we see it with more other respiratory diseases, and it's a very valuable thing to do, and it saves time, and it also saves patients not to be, the conditions is worse. But I must say it's a very good thing to have the RRT.
Thank you very much. And one of the important things is to know that we as providers, we're very used to just assigning out between each other. But if we can kind of give some form of sign out or have a readily available tool for sign out where people can also be able to just look at the People can be able to go in there and within a glance get what is most important to that patient. If something is happening at night, they can be able to easily understand rather than having to read the entire chart before they can really get a clue of what is going on. I think it's something that is going to help in any situation, even for your case where you have children with respiratory issues. If someone has a sign out and knows that this patient can easily deteriorate, they will pay more attention, they will see the patient in a timely manner, and it will probably even avoid getting to those situations where we have to be activating the rapid response teams. So our goal is to make sure that our patients do not get to that stage, which is an emergency situation, and which comes again with all the drawbacks that emergency situations can present. So I think it's something that we should consider a little bit more and look at it a little bit more vastly. Unfortunately for us, we couldn't do much because our sample sizes were, the number of patients were dropping a lot. Now we have just very few COVID patients in our hospital as compared to the number of patients that we had before. And so that explains why we have a lower sample size.
Do you use your muse and pews to call for a team? And also, who calls for the team? Is it the nurses? Is it the doctors? I know some places the family even can do that.
Yes, for us, any person who looks at the patient and like, I'm concerned about this patient. I think this patient is deteriorating. They can call the rapid response team. It's one button on the wall in the room. You press the button and they announce the rapid response team in the entire hospital. And every person who is a rapid response team member rushes to that area and rushes to that patient's room. That is how we activate it in our hospital. It doesn't have to be a healthcare expert.
That's very valuable because what we did is we have a delegated phone, but sometimes it doesn't work. So if you have a button and you can say it's a rapid response team thing that you need, it's not a code. It's actually much more valuable. As you know, is that manpower is getting less and less and less. You can't man a telephone, but if anybody can activate it, it's valuable and the team can go to that place.
That is correct. That is very helpful. You know, we have a very big hospital, and so people have to run from different areas to the hospital to come to rapid response. The last thing you want is someone trying to figure out how to call a rapid response. You know, that is the last thing you want. We have red buttons on the wall. If someone seems to be sick, you hit that rapid response, you hit the rapid response button, and it immediately registers to the front desk in the hospital, and they announce it overhead right away. Rapid response to room 5C129 or to the room, whatever room it is. So that is how we activate our rapid responses here in this hospital.
Sure. You know, what we do is we've got our monitor and our card and our consumables, and then the rapid response person goes with the doctor, and then we're going to assess the patient, and then we decide from there, if it's a code, are we going to escalate to PICU, or are we going to just manage what we need to do? But I can see this way of doing, your patient's complications are less because you already attend to the patient much earlier.
That is correct, yes. This was very helpful during COVID. Just reducing rapid responses during COVID was very significant. And not only because of, again, the manpower that is activated with these rapid response teams, but also with the PPEs, donning, doffing during rapid response. And there is a higher risk also of exposure to COVID when you're doing it in an emergency situation as compared to if it's something that you take your time, don yourself appropriately before you get into the room, or don off your PPEs before you get out of the room, you know. But in times of rapid response, in times of emergency, the donning off and donning off is of your PPEs is not that effective. It's very likely for you to make mistakes because that is the nature of emergencies everywhere. And so if you can kind of like calmly go to your patient, evaluate the patient, and stop the patient from getting into a rapid response situation, I think that is a better thing to do, and that is something which I think we should all look into.
I think that's true. Anybody with more questions for Joyce? I don't see any more questions. Joyce, this was very, very informative. And I can see the way it happens with us, but it's also so nice to know what other hospitals do and also other countries, because we all try to do best practices.
Exactly. You know, and again, based on our situations, we try to implement what we have based on our resources and everything. So I think it's important to kind of know some of the less costly things that can be done. I think creating a tool for people to sign out is very cost effective. It's cheap, and it can, again, what you can get out of it is very much.
Thanks a lot for your contribution. It was really informative.
Thank you very much for having me.
It's a pleasure.